Good afternoon, everyone. I am Catherine Brookman, Associate Director of Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar. This webinar is part of a graduate student research webinar series, a collaboration between CRE-MSD and the Association of Canadian Ergonomists, or ACE. As such, the facilitation of the question and answer period today will be led by my colleague Allison Stevens, Program Coordinator Professor, Advanced Ergonomic Studies faculty at Fanshawe College. We are grateful to the Ministry of Labour, Training and Skills Development for our funding, which supports the delivery of these webinars, and to our presenters who provide their expertise. The format of the webinar today is as follows. The presentation will be given, after which time we will have 10 minutes for your questions. Please remain muted for the duration of the webinar. Use the microphone icon in the control panel that appears near the bottom of your screen to mute yourselves. We ask that you type your questions into the chat box, and Allison will relay these questions or their themes should there be duplications to our presenter. Should you have a pressing question that cannot wait until the end of the presentation, such as a technology glitch, please type this into the chat box and we will do our best to address it right away. We will be providing you with a copy of the presentation shortly after the webinar, along with an evaluation link. We encourage you to complete the evaluation as it assists us in the future delivery and planning of our webinars. The presentation will be recorded and will be made available on the CRE-MSD events page in the near future. Now it is my pleasure to introduce you to our presenter. Victor Chan is a second-year PhD student studying under the supervision of Dr. Ryan Graham in the Spine and Movement Biomechanics Lab at the University of Ottawa. He previously received his Master's of Science in 2018 from the University of Toronto, studying under the supervision of Dr. Tyson Beach. The overarching goal of Victor's research is to develop worker-focused interventions to mitigate occupational low back disorder risk associated with strenuous and repetitive manual work. Thank you so much, Victor, for agreeing to join us today. And now over to you.
Awesome. Thank you so much for the introduction, Catherine. So first and foremost, I wanted to say thank you to CRE-MSD and ACE for this awesome opportunity to speak at this graduate webinar. Today, I'll be discussing my research on the prevention of WMSDs, or work-related musculoskeletal disorders, and how my research can be used to inform the creation of individual-specific interventions. Most of us here today understand the importance of primary WMSD prevention. They are the single largest contributor to lost time claims and costs in Ontario, but also worldwide. They also reduce the quality of life for those affected and negatively influence the productivity and services at work. Workers performing manual handling face an elevated risk for sustaining a debilitating WMSD, and my research looks to prevent the occurrence of such injuries. In relation to the WMSD prevention framework developed by Vanderbeek and colleagues in 2017, my research interests are situated in steps 4 and 5 on the framework, where I am focused on the development of preventative interventions and subsequently evaluate their efficacy. Specifically, I am interested in identifying effective approaches for interventions and analyze their efficacy in controlled settings. Although engineering controls, such as equipment provisions, such as powered ambulance cot or automated medication crushers and patient transfer boards, can be very effective in reducing or eliminating the physical exertion required to perform certain tasks, my focus is on the development of interventions to positively influence movement behaviors. Risk for overexertion injuries and WMSDs are still substantial, even with engineering controls, especially in occupations where variable and non-modifiable environments make it difficult to fit the job to the worker. such as in paramedic, firefighting, and construction work. Thus, interventions that aim to train and encourage workers to move in a safer manner remains an important and viable approach to supplement equipment provisions as part of a holistic injury risk mitigation strategy. Some of my research has evaluated the efficacy of commonly used methods to elicit spine-sparring movement behaviors, including the use of visual aids, such as lifting images used in posters, education, where workers are taught theoretical knowledge regarding safe lifting, and augmented feedback during training, such as knowledge of performance and tactile feedback. Because lifting images are used extensively in workplace and training programs, a group of researchers and I at University of Toronto posed the research question, can visual aids elicit changes in spine motion during lifting? So individuals were asked to replicate postures shown in these lifting images, and these were selected to display different amounts of knee and spine flexion. Using a lumbar motion monitor to accurately measure the spine movement, we found that there were significant differences in spine kinematics between these image conditions, indicating that images, such as those used in posters and pamphlets, can elicit changes in spine motion for lifting tasks. However, the greatest reduction in peak spine angles and velocities did not correspond to the image with the best spine position. Instead, individuals responded to the image displaying the least spine motion or peak spine angle by lifting with significantly more spine motion than the two other image conditions. The results of this study suggest that, yes, images alone can elicit changes in spine motion for occupational lifting tasks, but perhaps not the desired changes that are presented in images. Individuals might not be aware of where to direct their attention, or may have strength, mobility, or coordination limitations to perform the lift using a similar posture. Most likely, it's a combination of these factors. Regardless, these findings suggest that additional training or information is needed to highlight the key features depicted in the images used for this purpose. Of course, these visual aids are seldom used alone. They're often used as reminders or as part of training programs. Thus, we went further to study the effectiveness of different training approaches to influencing low back disorder risk factors. Training programs have traditionally used an education-based approach to teach optimal lifting techniques. Individuals are taught concepts regarding safe lifting principles, anatomy, biomechanics, amongst many other topics. Unfortunately, there is conflicting evidence to support this type of approach to movement training, especially as the existence of a universally optimal technique may not exist. Recently, manual handling training programs, such as those provided by Performance Redefined for firefighters across North America, have shifted their approach to training individuals to lock down key movement features, regardless of the movement or task performed. This is accomplished using augmented feedback to provide training cues, and limited theoretical knowledge and education is provided. One important movement feature I tend to focus on is the neutral spine, due to its implications on the load-bearing capacity of the spine during manual handling. Because the effectiveness of movement training programs have been under question, more attention to their contents is needed. So a group of researchers and I at the University of Toronto conducted a study to compare education-based, in other words, didactic, and feedback-based, augmented feedback, approaches to movement retraining, and their ability to reduce lifting-related low back disorder risk factors. In this study, both interventions offered 5 sets of 10 practice lifts, but only the didactic intervention included an educational lecture based on occupational health and safety guidelines. The augmented intervention instead provided brief individualized cues during practice, tactile feedback using a dowel, and real-time data-driven feedback regarding their peak sagittal spine flexion angle. These cues were administered in a manner guided by motor learning principles. Specifically, they received tactile feedback on their first 10 lifts, then received self-controlled knowledge of performance feedback in a faded frequency. In other words, they only received feedback when they asked for it and were told if it was better or worse than the last time they asked, and they had decreasing opportunities to ask for it throughout the sets. The augmented intervention took less time than a didactic intervention took to administer, but requires a method to provide individualized feedback, such as a coach. The didactic intervention may take longer to present, but it is easy to give to many workers at the same time. So the efficacy of both approaches were tested by quantifying the spine kinematics and low back disorder risk factors using optoelectronic marker-based motion capture. They were tested immediately and 1 week after the interventions during the performance of simulated paramedic lifting tasks. The loads they lifted were 5 kilograms for the box, 8.7 kilograms for the medication bag lifted using one arm, and 82.5 kilograms for the paramedic backboard, which was shared with the research assistant. When we tested both intervention groups 1 week after the interventions, both were able to elicit reductions in spine motion after 1 week. The didactic intervention significantly reduced 6 of 8 low back disorder risk factors across the box and medication bag lifts, but none for the backboard lift. In contrast, the augmented intervention elicited a significant reduction in the magnitude of at least 1 low back disorder risk factor across all the tasks. All 8 for the box and medication bag, and 1 in the backboard. These findings suggest that both approaches can be effective in eliciting reductions in spine motion compared to baseline, but more research will be required to determine if these changes can persist beyond 1 week. When the interventions were compared directly, the augmented intervention elicited either the same, indicated by an X, or significantly larger spine motion reductions compared to the didactic group, indicated by a UG. Thus, the results of the study demonstrate that providing individualized feedback without education can be more effective in reducing the magnitude of low back disorder risk factors, while requiring less time and teaching compared to education-based approaches. The takeaway from this study is that movement training interventions can be more effective in eliciting safer movement behaviors if individualized cues and feedback are emphasized over teaching theoretical knowledge. Although this approach may be more effective, a barrier to implementation may be the necessity of coaches or a means to collect the data and provide individualized feedback. Fortunately, new accessible technologies may enable this approach to movement training. Researchers and I at the University of Ottawa recently performed a large scoping review of 7 literature databases to survey the use of machine learning techniques in the primary prevention of WMSDs. What we found was that the most common use of machine learning was to enable real-time WMSD risk monitoring using unobtrusive measurement tools, such as wearable inertial measurement units, or IMUs, insole pressuring monitoring systems, and computer vision. Tools and systems like these may enable the provision of real-time feedback to workers and organizations, and could be implemented during training or on-the-job use to encourage safe movement behaviors or timely breaks. Many approaches have been proposed to gather and process useful information from as few devices as possible, such as attempting to recognize unsafe postures or estimate the inputs of ergonomic assessments. In a study we recently conducted at the University of Ottawa, we attempted to utilize a novel approach to recognize atypical spine movement, defined relative to each specific individual. We asked individuals to perform 50 spine flexion and extension movements in 11 sets or until they were fully fatigued. They did not receive any breaks between these sets. However, we did assess their fatigue levels using a visual analog scale, or VAS, and a maximal lift strength assessment. Their spine motion during this was quantified using 2 IMUs worn on their pelvis and their T8 vertebrae. A 10-feature spine motion composite index, or that we'll call the SMCI, was calculated for each individual for each spine flexion extension repetition. The SMCI is comprised of the peak thoraco-pelvic continuous relative phase, or the CRP, the repetition time for the flexion extension, and for both the pelvis and the T8 vertebrae sensors, we also looked at the orientation range, peak orientation, angular velocity, and peak angular acceleration. Briefly, these 10 spine motion variables were computed using the sagittal orientation signals from the two IMUs for each repetition. So the mean and standard deviation of these variables during their baseline trial was used to define individuals' typical movement behavior. Then, for every repetition in trials 1 to 10, the SMCI was calculated by quantifying these 10 variables, computing the Z-score of each variable relative to baseline, and averaging these Z-scores across variables. The SMCI represents the deviation in motion from each individual's typical movement. What we found was that the SMCI was associated with increases in fatigue, quantified using the visual analog scale and maximal lift strength. We found that the SMCI was significantly greater at trials 4 to 10 compared to trial 1. We also found strong correlations when averaged across all participants, and moderate repeated measures correlations across all individuals as well. Individually, the SMCI was significantly correlated to fatigue in 8 of our 10 participants. So some take-homes from this research is that wearable sensors can detect atypical movement associated with fatigue. This is important because fatigue often precedes movement behaviors that contribute to WMSD development, but can also be a precursor to occupational accidents. Because this approach quantifies the deviation from a worker's regular and ideally safe movement patterns, this approach can be used to provide automated, individual-specific feedback or cues to workers or their supervisors on any single repetition. This can be used in the form of audible or visual tactile reminders or alerts sent via mobile application to incorporate cloud computing, such as this early version of a mobile app developed in our University of Ottawa lab. Furthermore, such a system can increase the accessibility of augmented feedback approaches to movement training interventions. This approach is also widely applicable to a variety of repetitive tasks. For example, an approach like this can be used to quantify safe movement behaviors learned during training with a coach, then provide individual-specific feedback during their own practice or while working. This is a large benefit over monitoring using threshold-based systems because safe movement patterns can be very different quantitatively between workers. Moving forward, my PhD work looks to build on this approach as a WMSD intervention system by incorporating machine learning-based activity recognition and using composite indices that are task and individual specific to provide automated feedback across a variety of common tasks that workers may perform. So that's all I have for you today. Thank you so much for your time and attention, and I welcome all questions and comments.
Over to you, Allison.
Right. Well, great. Thanks, Victor. I've got lots of questions here because it's such fascinating research. So thank you. We have one from the audience. Do you have a sense if many industries or employers are using these wearable sensors right now, or are they largely in the research field? Victor, are you on mute? I'm echoing. Okay.
I am. Sorry about that. So that's a really good question. In terms of a sense of which workplaces and how often they are being implemented, I do not have a very good sense at the moment. However, wearable sensors have been used in different applications, such as for caregivers, such as the posture coach at the Toronto Rehab Institute, as part of a home care system to monitor peak spine flexion angles. So the use of wearable systems have been around for a while. However, there have been further developments in the approaches of how to go about providing feedback, which is still relatively in the early stages of development. For example, I'm seeing most of the publications regarding this topic come from 2016 and after, with the majority of these publications in this area coming in 2020. So it is still relatively early, so I'd expect it's not used as frequently in the workplace yet, but the goal will be to be able to implement them with relative ease in the future. So thanks for the question.
Yes, I echo that. I believe that the advancements of the wearables are coming in, and so this is going to be definitely an up and coming moving from research into the industrial world. We do have a question, and it's again about the approach.
Okay.
So what kind of priority would you give to this approach as opposed to trying to fix the job itself?
That's a really good question. So I'm not sure if I would necessarily say that we'd have to give a priority to this in terms of trying to fix the job itself. So that's not what I'm trying to kind of push for, but I'm trying to really emphasize that this may still be needed in occupations where it is very difficult to fix the job or fit the job to the worker. I'm not saying that there may be a priority that we should be given to one or the other, but it should be a supplement, if you will, to that kind of approach. So that example might be in occupations where the environment's very variable or non-modifiable, such as in caretakers where they're working in different individuals' houses, or in paramedics where they might be going to different locations where it's very difficult to fit the environment to them. Of course, there are equipment that we can use to be able to do so, but that goes to a certain way. At the end of the day, we still have to perform strenuous lifting in occupations like that. So again, to reiterate, I don't think that there's a priority we necessarily have to give there. When we can fix or improve that job, that's great and that's awesome. We know that that's sometimes limited in some occupations.
Cool. Kind of along that same line, then, if you are putting the onus on the worker, do you believe that there might be some blame the worker approach resulting from this kind of wearable technology, that they didn't listen to the feedback and maybe they should have?
Yeah, that's a really good question. So how do we kind of counter this approach that may result? So I think we have to make it so that's more important to the individual, not just for them getting hurt in the job, but also that it's an improvement to our quality of life, right? So this isn't a benefit of not only for the organizations themselves, but this is a big benefit that goes beyond that when we do our own things at home and performing your own exercises. So it's helpful to kind of see it in the lens that not only is it an onus on the worker to improve it just for the sake of staying in the work, but this is actually a good recommendation to provide to an individual, even for when they're accomplishing tasks of daily living, their own exercise, their own physical activity, for example. It is a bit challenging because at the end of the day, no one wants to be hurt on their job. However, there's something that we have to kind of share some of the responsibility, unfortunately, for individuals who have to perform repetitive, strenuous work. So that's a really good question. I think that's a larger picture question. Yeah, for sure.
And I think you answered it really well, Victor. I think you're absolutely right. We all have a role to play, and this kind of blame game is something that it needs to be of the past, right? We're all in here to keep everybody safe. So I think that's an excellent answer. A couple more questions. Do you have any specific recommendations for a wearable product?
That's a really good question. So I personally have been using the XSense system, and so that has been very, very great. One of them might be quite expensive, but is great for research purposes. So the XSense ambient software is also really great to use. I would also recommend to check out the XSense Dot because it has a mobile application for it as well. It's wearable and it's fairly inexpensive. So that's one that I would recommend, so the XSense Dot as well.
Okay, Victor, maybe at the end you could type that in, or am I going to spell it right? XSENS dot?
Yeah, I can type it out in the chat.
Okay, if you could do that, that'd be great. Then we do have actually one of the question about your actual study. How many participants were included in the trial, and how was this number decided?
So which study are they specifically asking about?
Well, I don't get that information, but maybe I don't know. Karina, can you maybe type in? We appear to have kept with the chat feature. If you have
Okay, well, you know what? One way I can answer it will be to, tell you, I guess, all of them. So we had 26 individuals when we compared our augmented feedback in our didactic training groups. We had 10 individuals for looking at our SMCI, so looking at the wearable sensors. And we had 18 participants and looking at our visual aids project. And some of these are typically decided upon based on looking at what the expected changes may be in previous literature. So what kind of effects are we looking at? And then performing a power analysis to determine how many individuals would be needed to be able to detect what amount of change that occurs in, let's say, the spine flexion angle. So we conduct a power analysis based on expected changes, and that will allow us to recruit the correct number of people to be able to see differences that we may see. In terms of looking at an individual specific approach, that typically requires a bit less individuals because we are looking within an individual. So some studies that have been looking at individual specific approaches might have as few as one individual. Obviously, to have more would be great to speak to some of the generalizability of it. But sometimes with a specific subject-specific approach, less individuals is viable as well. So it's a good question.
Yeah, I think you answered it really well. So basically, if it's more specific to an individual, you don't need as many and more in the generalized. Now that I actually had a question on that a little bit. So you're learning someone's patterns. Can it do, I know it said you could do a highly repetitive task. What if the task has multiple types of lifts from different horizontals and verticals?
Yeah, that's a really great question.
Is it capable to do that?
Yeah, that's a really, really good question. That's actually something I'm interested in. So that's actually a big challenge for using sensors to accomplish, especially because we typically look to use few devices. So a lot of the research right now is looking at how can we best recognize this activity, and machine learning turns out to be a very good tool for activity recognition. So moving forward and able to determine how much they might deviate from their relatively safe or proper way of performing one specific task, I'm looking to pair up machine learning with the use of these composite indices to determine what task it is that this individual might be performing, then calculating to see if it is deviating far from what they typically or when they learned how they were performing it. So that's a really good question because using it across many tasks is a really big challenge, especially with devices like these. But machine learning is actually a really good tool to be able to tackle this. So
great. All right, I'm going to combine the last two questions here, just due to our time.
Yep.
Does the location of the wearable matter? And have you heard of a case where maybe something like the WSIB might be able to support covering the cost to help with the return to work sustainability?
Okay, so yeah, these are both really great questions. So I'll answer the first one first. So does the location of a wearable matter when it comes to collecting data? It matters a lot for sure, depending on what it is that we're looking to collect. For example, in some gait analyses using wearable sensors, we tend to like to put them on locations such as our ankle. When we're looking at a whole body tasks, research has just come out of our lab to look at how few sensors can we kind of get away with while achieving sufficient accuracy of determining what task it might be. And it looks to be that the IMU sensor on the trunk is actually quite important. So that is actually one that is really important for detecting where it is, what task we might actually be performing. This might be linked to the fact that it's located relatively close to our center of mass. So yes, to answer your question, it does really matter where it is we're putting our wearable sensor. Oh yeah, sorry. And for second one, is this wearable technology at a wide scale level? So again, so the actual technology for the actual sensors themselves are available at a wide scale level and relatively inexpensively. However, the approach to be able to analyze an individual's movement and determine when it is they might be facing some fatigue or changing their movement patterns in unfavorable ways is not at a wide scale level. So that is currently still in development. And if it's something that the WSIB would be able to cover, that I'm unfortunately not too sure of, so I don't want to speak on that. Those are really good questions, important questions.
Well, I
Yes,
want
and
to
I think
thank
as
you,
they-
Allison.
Yeah.
And Victor. What a great Q&A session. And Victor, thank you so much for your insightful presentation, and Allison for your facilitation. I think this time slot is definitely working given the attendance we've had today and the interactivity. So I do encourage all of our participants to watch the CRE-MSD website for upcoming webinars in this series with ACE, and also encourage you to watch both the CRE-MSD and the MSD Prevention Guideline website for new resources. Thank you all very, very much, and we look forward to seeing you again. Have a great rest of the day.
Thank you.